Welcome, everyone, to this edition of the Healthcare Labyrinth Podcast. My name is Marc Ryan. It's a pleasure to be your host on these podcasts. We hope you are enjoying the podcast. This is the fifth episode that we've done. We started about a month ago, and so we're very excited to be doing this. I wanted to start off, as I normally do, to give you a brief overview of the Healthcare Labyrinth website, healthcarelabyrinth.com, and what we do. So number one, really quickly, we do a daily weekday news feed where I offer some commentary and summation of leading healthcare articles of the day after my perusal of about 24 sites out there. Number two, we do a twice weekly blog on topics, perhaps from the news feed or other major topics I come up with, including requests from listeners and readers. And most recently, as an example, I did a blog on risk adjustment, what it's all about, and what is this controversial risk adjustment data validation rule. And my latest blog, just out this week, has to do with drug pricing and some studies that have come out. One of the reasons I'm doing this podcast today. And lastly, the podcast, which is done once a week and covers various different categories of healthcare out there. So again, all of this, the news feed, the blogs, and the podcast available at healthcarelabyrinth.com. At that website as well, you can purchase my book, The Healthcare Labyrinth, which continues to do very well in the Medicare and Medicaid and health policy areas in sales. So let's get to the podcast. Again, the topic today is drug pricing in America and a brief review of the Inflation Reduction Act's Medicare drug pricing provisions. So let's start out first with a bit of what I call an admonition, just so you know where I come from. So I am a Republican, as I've told you on a number of the other podcasts, but I hold a somewhat atypical view, I think, on drug prices for my party, at least compared with the House and Senate GOP lawmakers. But I would say I think my views on drug pricing and what we should do moving forward for reform are perhaps not as out of the mainstream of the Republican Party as I might initially seem. So I usually look to a couple of different things here. Number one, the current president and former president, so Joe Biden and Donald Trump, different parties, but they've actually proposed similar reforms on drug pricing. President Biden obviously advocated and sought the passage of these Medicare drug price provisions within the Inflation Reduction Act. And President Trump, when he was in office from 2017 to early 2021, actually proposed a number of ways to reduce drug cost, including using international reference pricing. And we'll get a little more into that in the future. So believe it or not, a Republican and a Democratic president proposed similar types of reforms for drug pricing. Number two, I always say there are respected sort of, I'm going to call moderate mainstream think tanks out there with bipartisan representation that really do support drug pricing change as well. And they are advocating for some of the things that I'm going to talk about today. And lastly, if you look at polls across party lines, there's clear support for really drastic changes to how we set prices and the need to lower drug prices. So again, I may not be advocating views of my party from the standpoint of who currently is in the House and Senate on Capitol Hill, but I do believe my view is a little more mainstream than you would think. Let's get a little bit into, if you did want to suddenly set prices on drugs in our country, is that somehow anti-free market? Well, my view is not at all. The truth is that negotiations and contractual arrangements are a cornerstone of the free market. That's exactly what the free market is based on, the interchange of ideas, coming to agreements, and things like that. But more importantly, I'd also note that the drug market isn't exactly a free market anyway. It lacks transparency, and often the players in the drug chain don't even know what price is set for a given drug. There are monopolies and oligopolies in the drug supply chain that would make even our famous trust buster President Teddy Roosevelt blush. And lastly, I would also note that Medicare or national drug price negotiations, depending on how quickly we get there, would do exactly what we're doing today at a more transparent and at a higher level. And what do I mean by that? Well, PBMs and plans and employer groups today have formularies, and that's basically what drug price negotiations are all about. They negotiate every day with drug makers on various issues, including costs and what does or does not make sense to place on a formulary and where in the tiers on the formulary those drugs would go. So the Medicare or even the national government over time would be doing really the same. They'd be setting a formulary, they'd be negotiating prices. But what's important to remember is under that way of negotiating prices, we'd have a much more transparent clinical and financial rules that would be followed. And we would be getting out of this opaque supply chain system that really creates perverse incentives and things and financial arrangements that go on behind the scenes that inflate drug prices and, again, do not create the kind of transparency we need in drug pricing and in the drug market in general. What the drug makers wouldn't like about that is, again, they could not use all sorts of perverse financial arrangements that lack that transparency to influence decisions on where an individual plan or PBM may place a drug on a formulary to ensure that the drug continues to have market share. I would also make one last point that ties back a little bit to really members of all parties and influencers in all parties think drug price reform is needed. I think everyone really does believe, even if they believe in private free markets, that government has an absolute obligation to regulate healthcare because it is something very crucial to every American's well-being, and that government should have some reasonable regulation on access to drugs and medical services and furnishing health insurance. In many ways, government acts as a fiduciary for people's long-term health and financial well-being. That's clearly true in the area of healthcare, and that's what government does in general, and we should not be ashamed of it. So just a quick overview of my positions in general on drug pricing and how, while at first blush they may appear to be not Republican or not in the mainstream of the Republican Party, they actually might be. And who might not be in the mainstream currently are some of the lawmakers in Congress. So let's next move on to a couple of fundamentals about drug prices in America. So number one, it's important to remember that over the last, I would say about 6 decades, about 60 years, about my lifespan, starting back into the early 60s, we have seen drugs move from being a fairly very small, de minimis amount of healthcare to something that is a material overall cost driver. Now, there's a couple of things here. Number one, on the positive side, drugs have come into the mainstream of healthcare and are a very, very important of health maintenance. No question at all. And many drugs are saving lives. So no question about the positive benefits of drugs. But as I alluded to, at the same time, over these past rough 6 decades, we have now seen, again, from a financial standpoint, drugs coming from a very small amount of the overall healthcare pie to a dramatic amount. And they are becoming the single largest cost driver, fighting with inpatient coverage from an inflationary standpoint about who is growing more each year. In rough measure across the entire healthcare system, retail drugs are somewhere about, round numbers, let's say 10% of overall costs. If you include very expensive medical drugs for cancers and things like that are infused at facilities or a physician's office, that number is probably more like 16+% at last calculation. And the two of them are driving together toward that 20% mark due to inflation. So again, that's how it's become very material over the past 6 decades or so. The second point I make generally about the fundamentals about drug prices in America is the fact that drug spending is driven largely by brand drugs. The vast majority of drugs utilized out there are generic drugs, but they are relatively cheap. And that small percentage of brand drug spending is actually driving overall costs because brand drugs are so much more expensive. Brand drugs on a retail basis are hundreds of dollars in round numbers a month for a 30-day supply for consumers, whereas a generic drug is down in the probably about on average $20 or so, with some slightly more. And there are specialty and other drugs that are in the thousands of dollars a month. And when we think about medical drugs for a treatment, episodes for medical drugs can be in the tens of thousands or even in the hundreds of thousands of dollars. So brand drugs very much drive costs in America. The third point I'd make about fundamentals is that America's drug prices are extremely high compared with other developed countries. Later on, I'm going to tell you a little bit about the 10 drugs and their pricing across the world compared to America. But in general, what I also always say, and I say this in my book, you can basically say that Americans pay more than double on a net basis of what other developed nations do. What's a little unique about America is we have very, very high, what I call gross list prices compared to the rest of the world. We have these rebates and discounts that occur after a drug sale actually happens that drive down certain costs to a net basis. But even those net basis costs in America, we pay more than double what other developed nations do. In some studies, that difference on average, looking at specific drugs, can be as much as 4 times higher. And it's also true that given drugs out there can also be even more expensive compared to other developed nations. So in general, we pay more than double. And in certain drug categories, it's many folds even more than that in terms of costs. Fourth fundamental here, we are the only developed nation in the world that does not negotiate prices nationally. In an earlier podcast, I told you about the 3 types of healthcare systems that nations have. Number 1, socialized medicine. Number 2, single payer or affordable universal access. And in all of these 3 systems, again, drug prices are negotiated sort of at a national level. We do not do that. We theoretically have what you might call free market setting of prices. But again, as I pointed out, the drug market is not a free market. So I think that's not exactly right to say. But nonetheless, America is the one developed nation that does not price set or negotiate at a national level. And prices are sort of freely, quote unquote, set by drug makers and other entities in that drug supply chain. Again, if you want to hear again about the various system types out there, you can go to an earlier podcast and learn a little more about that. And my last, I would say, fifth and final fundamentals about drug prices in America revolves around whether innovation will be impacted. And we're going to get a little deeper into this topic, but brand drug makers will argue that if suddenly drug price negotiations occur in Medicare, which drives a lot of spending in America on drugs, suddenly is impacted, or if we ever had national price negotiations, that somehow Armageddon would occur and all innovation in the drug world would suddenly come to an end. Well, there could be some impacts, but most studies, and we'll get a little more into the details, seem to indicate that impacts will be fairly minor, and that there are ways to overcome any innovation impacts, including, for example, spending more dollars on government research, which the drug manufacturers will not admit. Government funding often plays a critical role in some of the most important drug innovation out there. So that is just sort of the quick fundamentals and some admonitions about my views on healthcare and how they may not look particularly Republican, but probably are more Republican than most lawmakers anyway would admit. Let's next talk about how drug prices are set within the United States and in other countries. We're going to start off with the United States. I think the most important thing that I've referred to already is that there is a very opaque drug supply channel in America. It has many different actors. It desperately needs to be simplified because there's a whole bunch of complexity, confusion in terms of how drugs are actually supplied and what those prices and costs are going to be. So let's talk first about the relationship of drug makers with PBMs, health plans, and employers. Principally what happens here for brand drugs largely, because there are no rebates usually for generic drugs, but these PBMs, health plans, and employers enter into discussions with drug manufacturers. Sometimes these negotiations occur between PBMs and what are known as drug aggregators with the brand drug makers. But basically what occurs is PBMs, health plans, and employers negotiate with brand drug makers rebates on these brand drugs. And these rebates can often be very, very generous. This is one of the big components of getting from a list or gross price down to a net price. And these rebates sort of determine, number one, whether a given drug is going to be on a drug formulary for the PBM, health plan, or employer. And number two, where it's placed. And both of those can really determine market share for a given drug by a drug maker. So rebates can be higher or lower based on if the drug is on a formulary and where it's placed on that formulary. So this is one important part of drug negotiations, the negotiation, the rebate, and some other discounts between the brand drug maker and then PBMs, health plans, and employer groups. Below the drug makers are a series of middlemen, principally wholesalers, who get their generous share of profit as well. I talk about the fact that, brand drug makers have, say, a 20% margin over a given period of years on average, but wholesalers get their generous profit as well. And they are, again, acquiring drugs from manufacturers, and there are various fees and transactions that apply here. And then the wholesaler will contract with pharmacies for the actual supply of the drug. And there are a whole bunch of fees charged by the wholesaler to the pharmacy to get those drugs. PBMs, again, along with rebate aggregators, contract with health plans or self-insured employer groups to administer drug benefit plans. including claims, network rebates, and quality oversight. The relationships between PBMs and health plans or employer groups historically have lacked transparency too, with plans and employer groups complaining that PBMs are not open about the relationships they have upstream and that actual drug prices are not easily quantified, especially regarding the retroactive rebates and other reconciliations that happen with pharmacies. PBMs then contract with pharmacies. These relationships are complex, with point of sale payments made by the PBMs to the pharmacy, as well as retroactive adjustments and clawbacks that the PBMs have with pharmacies that reconcile final payments. So network and volume can play a big part in payments from PBMs to pharmacies. Preferred and non-preferred status also play into those relationships. Again, pharmacies here complain they often cannot tell what their final payment is going to be for a drug transaction because of some of those retroactive adjustments and clawbacks that occur. So that's just sort of a quick look at price setting and costs of drugs in the system. And again, in summary, we have health plans and employer groups and PBMs that are working with drug makers. We have wholesalers working with drug makers. We have PBMs contracting with health plans and employer groups. And we have PBMs contracting with pharmacies. So all of that ties into price in this opaque system, and not sure what that final price often is across the board. And all these various entities are making money in this supply chain, which adds to costs as well. And then, of course, we have very high brand drugs out there. And so the important thing to remember here is that with each transaction, there can be multiple payments or parameters that impact price. And again, little of this is understood by the public. Other countries have national drug price negotiations where various public or private groups at the national level usually are negotiating with brand drug makers as to whether a drug will be placed on the national formulary and what that price may be. And so essentially what occurs is there are these discussions, as I just outlined, between the drug makers at the national level. And these countries basically sort of think about two questions in that negotiation. And to some degree, those questions are going to be asked in Medicare drug price negotiations in America too. Number one, is the drug more effective than other drugs in the market for the given disease state or condition? So there's a little bit of a clinical evaluation that goes into these drug price negotiations in other countries. And then second, is the drug cost effective? In these countries, they're looking at the financial cost effectiveness as well as that comparative clinical effectiveness. I would also note that after or during these negotiations, some countries also use what is known as international reference pricing to determine the final price and whether a drug will be placed on a formulary. International reference pricing basically is where a given nation is looking at the prices of drugs in comparable nations out there, or perhaps even developed country prices, to determine is the price that a brand drug maker is offering during negotiations reasonable? And does the price need to move further down toward what other developed or developing nations are paying in order for that drug to be placed or included on the national drug list or formulary? In some cases, these nations want to be the lowest priced out there. In other cases, international reference pricing is used more as a barometer. Is it within a given range? And is that price thus fair to place the drug or include it on the national drug list? And so that is essentially, in a rough nutshell, how these drugs are priced in other developing nations. I would also note that some nations also practice individuals paying 100% of the difference between the drugs allowed by the healthcare system on the formulary and one that is not. That effectively kills that drug's market share in the country if you're not on the formulary. This is known as reference pricing. Don't confuse it with international reference pricing, but it's a new transparency initiative to guide individuals to the most cost-effective drugs or services. Again, if they choose a higher cost drug or service, they're going to pay the difference between the formulary item that treats the same disease state or condition and 100% of the difference between that drug and the drug that they would like to go on that is not on the national drug list. But again, when this occurs, the market share of those non-formulary drugs basically collapses in that nation. I would note that this process in developing or developed world countries actually to some degree does exist in the United States. So a good example is what is known as the Federal Supply Schedule, which offers very discounted pricing of brand drugs and other drugs to certain national and other healthcare programs. And so this Federal Supply Schedule is negotiated. Discounts are deep, well beyond even the net cost of a drug after rebates, and various entities basically are allowed to tap this Federal Supply Schedule at deep discounts. And so again, there is a parallel in the United States in a small way to what occurs in developed nations out there in terms of drug price negotiations. So let's now get on to the Inflation Reduction Act's Medicare drug negotiation provisions. So currently, as many of you know, the Part D program is really in two parts. One, Medicare Advantage plans can offer Part D coverage, and therefore they have medical and drug coverage all under one roof. In other cases, for example, Medicare fee-for-service individuals may also enroll in a standalone Part D plan. And both the standalone Part D plans and the Medicare Advantage Part D plans are private entities. The Part D retail drug component is delivered via private entities. In the case of Part B drugs, Part D is retail, Part D as in dog, retail, Part B as in boy are the medical drug spending. That is covered by a Medicare Advantage plan under Part C or through the fee-for-service program if somebody is enrolled in the traditional program. So when it comes to, let's start with Part B drugs. By and large, these drugs are reimbursed generally in the traditional fee-for-service world through a formula called average sales price plus 6%. And obviously that favors, in some cases, the provision of brand drugs because those drugs are much higher and individuals can make more money through an ASP 6% on a brand drug versus a generic drug. Some Medicare Advantage plans that, again, cover the Part B medical drugs through Medicare Advantage have deviated a bit from that. But nonetheless, that is the prevailing way of reimbursing for medical Part B drugs, which is ASP plus 6%. In the case of Part D retail drugs, there are, a number of different reimbursement patterns there. First, if it's a brand drug, generally speaking, the standalone PDPs or the MAPD plan negotiate through a PBM for an average wholesale price discount for reimbursement of that brand drug. And so those are sort of the two major component pieces in terms of current reimbursement, ASP plus 6% for Part B medical drugs, and AWP minus some discount for retail drugs. Then, of course, as we talked about, the brand drugs have rebates that are retrospective after that come off as well. But as we've indicated, a very, very expensive system. Today, the private entities have what's known as the non-interference clause, which means the federal government is unable to interfere in the negotiations between the PDPs or MAPDs with brand drug makers. Again, many of them do that through an intermediary PBM and even rebate aggregators. What does the Medicare drug negotiation provisions within the Inflation Reduction Act do? Well, first, it amends that non-interference clause by allowing the Secretary of HHS to negotiate prices with drug companies for a small number of certain Part D and Part B drugs. It rolls out over time, a small number in the beginning, a larger number later. But for 60 drugs over time, the non-interference clause is lifted for the HHS secretary to negotiate prices for the drugs that are chosen for inclusion. After that, it's up to, again, the plans and the PBMs and the PDPs, in essence, to essentially set prices for other drugs, unless the Inflation Reduction Act provisions are expanded. So under the new drug Medicare negotiation system, in 2026, theoretically by 1/1/26, there will be 10 Part D drugs that will be subject to this HHS secretary negotiation. In 27, theoretically 1/1/27, an additional 15 Part D drugs would be eligible. In 2028 is when Part B medical drugs come into the picture, and in 2028, another 15 Part D and or Part B drugs come into the negotiation equation, and finally another 20 Part D and Part B drugs come into the picture for 2029 and later years. So again, if my count is right, it's 60 total drugs over that period of time subject to negotiation. These drugs will be selected generally from the highest volume Part D and Part B drugs, the highest 50 in each category, Part D and Part B. And obviously, as more drugs come into the equation, there's a larger universe of drugs that could be subject to negotiation. Now, without getting into this sort of weird specifics of exceptions, there are some drugs that are excluded from the negotiation process. So even if they're among the top 50 Part D drugs or the top 50 Part B drugs, some of them may not be eligible for negotiation. So, for example, drugs that have a generic or biosimilar available would not be eligible because this is largely targeting brand drugs without competition. Drugs that are less than 9 years for small molecule drugs or 13 years in the market for biological products from their approval or licensure date would not be eligible either. There are some other provisions, but those are sort of two of the biggest exclusions. And this is meant theoretically to protect certain drugs that may have orphan status, for example, is another one, or spending is less than a quantifiable amount, or again, they have not been in the market for enough tenure. So exclusions exist, but by and large, then they focus outside of those exclusions on the 50 Part D and 50 Part B drugs with the highest total spending in either program to determine what drugs come into the picture. And so we'll talk about the first 10 drugs that have been picked very shortly. I want to go on, though, and talk about how this negotiation sort of rolls out. And in some ways, it picks up on some of the themes in terms of how other developed countries negotiate drug prices as well. So the law establishes an upper limit for the negotiated price for a given drug. And basically, that is sort of the quantifiable understanding of what the maximum amount that would theoretically the drug would be priced at. When negotiating that maximum fair price, the secretary is required to consider a number of areas. So, number one, the amount of research and development investment into the drug, the current unit costs of production and distribution. Both make some sense, right? We do live in a free market and we should consider those parameters. On the flip side, the secretary also will consider any financial support from the federal government for some of the discovery and development of the drug. And as I've pointed out, there is a significant amount of federal drug support out there that private entities rely on. And there are a number of other different kinds of sort of, I'm going to call financial or metric-y types of requirements to consider. Next, moving toward more clinical, and again, this is where we see some overlap with what goes on in some other developed countries. The secretary will look at alternative treatments. And in this case, the secretary will really look at what you would think of generally as therapeutic alternatives. Maybe not obviously the exact composition of a drug compared to another, but those that are in that same therapeutic type class, they are basically prescribed for the same disease state or condition. And so as the secretary is looking at the evidence of alternative treatments, they're looking at, is there a therapeutic alternative in the market for a given drug? What is the uptake, as an example, or other information related to these therapeutic alternatives in the market? The law also speaks to comparative effectiveness of the drug against the therapeutic alternatives. Is the drug that is in price negotiations here have some better effectiveness within this rubric of therapeutic alternatives? So do they, treat special populations and things of that nature? So comparative effectiveness would be considered in terms of deciding what that price would be. Now, theoretically, after the clinical and the financial considerations are made, the secretary will, negotiate with the entities for a given price. Once that fair price is set, that would become the reimbursement. In the Part D world, that would be the reimbursement. In the Part B world, there would be a 6% add-on because Part B drugs have to be administered by physicians or other providers. So that, in essence, is how things would work. As I told you, the 10 drugs that are going to be part of negotiated prices as of January 1, 2026 have already been announced. We're going to go through those. But there's basically a timeline that's been laid out for the process. So it is roughly about 2 years. So again, the initial drugs came out in the fall of 2023, and they would be effective 1/1/26. So roughly about 2 years. And there are a number of steps in between there that will occur. Let's take the January 1, 2026 drugs first. So basically, the drugs have been announced again as of about fall, as of about September of 2023. And it was based on previous spending data in terms of determining were they among the top 50 Part D drugs. The period of negotiation between HHS and manufacturers will occur between October 1 of 23 and August 1 of 2024. What if a drug manufacturer refuses to arrive at a maximum fair price? So far, all the manufacturers of the 10 drugs have agreed to stay in because they don't know what's going to happen with their lawsuits against the program. So they had to agree to come to the table. But if they weren't to arrive at a maximum fair price, there are a number of different penalties that are put on the manufacturer for not agreeing to participate. It does open up the possibility that these entities, these drug makers, could decide to pull their drugs out of the Medicare and Medicaid program. So that is an alternative. And that was really put in probably to avoid any legal ramifications and to ensure that a lawsuit is in the favor of the federal government rather than business groups and drug makers. So after you arrive at a maximum fair price in the first round here, there's a rollout of a little over a year. There's a rollout education process, notices, and things of that nature after the fall of 2024. And the drug price would become effective 1/1 of 26. Now, in the subsequent yearly rounds, as we move up to a total of 60 drugs, the calendar is slightly different, but in rough measure, there's this rough period of time of negotiation and notice before each year that new drugs have a maximum fair price set up to the total of 60 drugs out there. Let's now take a look at the drugs that are included in the first round of negotiations. I've been talking about the fact that there are 10 drugs chosen in the first round. Well, that's not exactly correct. I didn't want to cloud what I was saying earlier, because there are actually 10 drugs based on the Part D and the Part B spend that I told you about. But insulins are also automatically in the negotiation process. So there have been some reform of the price of insulin already in the Part D program, capping cost sharing as an example. But insulins are automatically sort of in as long as they have enough spend as well. So there's 10 drugs plus the insulins. And let's talk a little bit about the drugs for 1/1/26 negotiations. So number one, Eliquis is a drug that prevents blood clots and stroke. Jardiance treats diabetes, heart failure, and chronic kidney disease. Xarelto prevents blood clots and stroke. Januvia treats diabetes. Farxiga treats diabetes, heart failure, and chronic kidney disease. Entresto treats heart failure. Enbrel treats rheumatoid arthritis, psoriatic arthritis, plaque psoriasis, and some other disease states. Imbruvica treats certain leukemias and lymphomas. Stelara treats Crohn's disease, plaque psoriasis, and psoriatic arthritis. And then there are a series of insulins, again, that are included in drug price negotiations as well. And what's interesting about these drugs overall is they are, and it goes without saying, that they are drugs that treat a lot of disease states that seniors have, primarily heart issues, diabetes, arthritis, and things like that. So those are the 10 plus insulin drugs that are covered in the first round of negotiations for 1/1/26. So let's get back to the issue at hand. I made the case earlier that number one, the price of drugs is outlandish in the United States, and I gave you some stats on that. And number two, I basically said that I did not think, and a number of studies sort of show, that innovation will not somehow be crippled and the sky will not fall if we have Medicare drug price negotiations. So in the past few weeks, there have been two important analyses or studies that came out. Let's talk the first one. So the first one really focused in again on the cost of the 10 drugs that are in the first round of Medicare drug price negotiations, and it compared the United States drug prices against the developed world. Now, as you can imagine, it's a little bit difficult because there is not this concept of gross and net prices in the developed countries. They negotiate a price, and that becomes the price of the drug in every country besides the US. Again, here in the US, we have these exorbitant list prices. We have these behind-the-scenes discounts and rebates that come to a net price. But anyway, the smart guys out there in the world basically came together under the auspices of the Commonwealth Fund and basically using some internationally recognized analysis tools, basically sought to figure out how does the U.S. net drug price and gross drug price compare to the one price out there in each of the various countries. So number one, this study encompassed the following countries in addition to the United States, obviously: Australia, Canada, France, Germany, Japan, the United Kingdom, and Switzerland. And again, what I think is interesting is back to my three healthcare system types. These countries, besides the United States, represent all three types. So it sort of proves that we have low drug prices, you'll find out, in really all three system types. The drugs 2021 prices in each country were looked at against the gross and net prices of of the 10 U.S. price drugs. And again, the researchers really say this kind of analysis is going to be really key in terms of benchmarking going into the negotiations for 2026. This kind of analysis, along with the clinical effective analysis we talked about as well. So the Commonwealth analysis here found that the list prices, this is our gross prices in the United States for the initial 10 drugs selected for negotiation in Medicare, are about 3 times higher than the prices in other developed countries. Well, that gives us a glimpse of list price against prices in other countries. But when you look at factoring in rebates and discounts, the net prices in the United States are still well higher than other countries. There was one exception out there in Japan. Janssen's Xarelto was more expensive in Japan on a net basis in the United States, but that was the only exception. On a gross and a net basis, for every other drug, the United States was demonstrably over what the other prices were in developed countries. And so just a note here, when they moved from the gross prices to the net prices, it was determined that rebates ranged from 9% to 50% from gross to net in the United States. So that shows how big some of these rebates really are. And as I often point out, it's not always the case, but in a lot of cases, the poor consumer is paying his cost sharing based on gross price, not net. So sizes of rebates really impact how much somebody pays in this current environment at the point of sale pharmacy. So just a little bit more on this. I had to do some of my own mathematical calculations. And what I found for net U.S. prices against the developed world prices is that the U.S. prices range from 30% to 270% more for the 10 drugs than in the other nations. And that is absolutely significant. And again, this is based on the U.S. net prices. The average overage in the United States in terms of cost was about 134%. So roughly in the middle of that 30% to 270%. So I mentioned the fact earlier that U.S. prices are more than double other countries. And I also noted another study that certain drugs can be as much as 4 times higher. So what this study is saying, finding net prices 30 to 270% greater, clearly substantiates the fact that in general, U.S. prices are more than double. And when you get up to that higher end of the range, it also substantiates that certain drugs can certainly be as much as 4 times higher in the United States than in other developed countries. So let's talk a little bit about spending for these 10 selected drugs. So there was a report issued by the Department of Health and Human Services around the time that the 10 drugs were announced that indicated that the 10 drugs represent about $46.4 billion in total Medicare drug spending and about $3.4 billion in out-of-pocket costs for beneficiaries. This was for calendar year 2022. About 7.7 million Medicare enrollees, or about 15% of the Part D members, used one or more of the 10 drugs. Overall, total Part D gross spending for the 10 selected drugs more than doubled from 2018 to 2022. And again, that was probably utilization as well as price increases. And that spending went from about $20 billion in 2018 to about $46 billion in 22, an increase of about 134%. The rate of growth in spending for these 10 drugs is more than 3 times as fast as all Part D drugs over the same time period. So one of the reasons that these drugs were selected. In addition, 7 of the 10 drugs received an R&D tax credit from the U.S. federal government, an example of the federal government supporting development, both in grants as well as obviously in these tax credits. And one of the 10 drugs has a government interest patent. So very interesting information related to the 10 drugs and the amount of spending. Let's move on to a second study. So I told you that the prices are well out of whack compared to developed countries in America for these 10 drugs. Let's also talk a little bit about what is currently being said about the IRA's impact to drug maker innovation. Well, another study released recently basically answered the question, will the IRA impact drug maker innovation, with what I call, right now, it is not occurring, at least not yet, right? That's sort of the answer there. And the policy brief was issued by the research and consulting firm ATI Advisory. And it found a couple of different things. So I'm going to just read a couple here. Number one, most drug companies' innovation decisions in the first half of 23 were not directly linked to the passage of the IRA's Medicare drug negotiations, but were really sort of a response to economic and company trends in the industry. This holds true for planned R&D spending as well as pipeline discontinuations. So in the area of innovation decisions, planned R&D, and pipeline discontinuations, the IRA AT Advisory concluded has not yet really influenced those kind of decisions. ATI Advisory also listened in on drug company earning calls, and these are the calls that are held on a mandatory basis, sort of annually, but also every quarter, to basically give investors a look at the company. And they are also accompanied by disclosures that are filed with the Security and Exchange Commission. And so ATI, in reviewing those earning calls, basically said that they indicated that the U.S. market remains a key priority. Back when the IRA was passed and prior to it, the drug manufacturers, the brand drug manufacturers, were arguing that they would immediately turn their focus somewhere else if Medicare drug price negotiations was passed. Well, at least in ATI Advisory's opinion, right now that is not occurring, and the earnings call tend to call out the fact that the United States remains a key priority? Well, in many ways that makes sense, right? Because the U.S. is the biggest market. In general, somewhere around 70 some percent of all margins come from the US market. That's in part due to the fact that we're a very large developed market and we're very sophisticated, and also obviously because we have high drug prices. So it's hard to argue that drug makers were going to immediately turn away from the United States as a key priority. And the last area I'd call out from ATI advisory is that domestic investment is up rather than down. So they have not pulled back from investing in the United States because of the IRA Medicare drug price negotiation provision. The firm does say that decisions will eventually tie to the IRA. That makes sense. And there are also some small inklings pointing in that direction. So ATI noted that some firms are prioritizing research and investment to reach the market earlier, that they're trying to accelerate the development of certain drugs and investments to get into the market earlier. That would have the impact of accelerating revenue in the short term and perhaps reduce it in the later years of the drug life cycle. But as ATI notes, this is exactly what the IRA was intended to do and wants, to bring brand drugs to the market earlier, control some costs, promote generic penetration by allowing generics to come in as well. So in some ways, if the IRA is starting to play a role, it's actually what the IRA was intended to do. So again, various brand drug industry and industry-aligned studies argue there will be an enormous impact on drug maker revenue and thus innovation and the number of drugs coming to market. But other studies, including one from the Congressional Budget Office, argues that the impact will be pretty minimal. At least so far, ATI Advisory's work sort of shows maybe on the side of being more minimal. The truth is probably somewhere in between, right? Brand drug makers will argue that it will mean lower life expectancy and impacts on Americans' health if more drugs do not come to the market and you peel away some of those drugs. I would note at the same time that we have some of the worst health outcomes due to the high drug prices, and many Americans simply can't afford the high prices of drugs and therefore are not taking them the way they need to. And thus, if the brand drug makers can argue that less new novel drugs coming to the market will impact life expectancy and impact health outcomes, I would argue, however, that we already see that in the United States. We have lower life expectancy and lower health outcomes because of high drug prices, and that serves as an issue related to access and continued use of those drugs. So we already see high drug prices having a deleterious impact on outcomes. I'm not trying to say that certain new novel drugs might not come to the market, but we already have impacts from the drug industry that are negative. And I would argue that we could overcome some of the lower innovation in other ways, like better government investment. So in the end, the IRA's Medicare drug price negotiation provisions start us down the road that is used by every other developed nation, and these developed nations have better health outcomes. While it's limited to Medicare right now, there is hope that it will be expanded, for example, to the commercial world, and maybe even to the Medicaid world, which has this funky, administratively burdensome retroactive rebate system that could benefit from upfront price transparency as well, for sure. The IRA, too, could be extended to include some other key features in other developed nations, including patent reform and other research and clinically based approaches to make sure that the price we pay for drugs are fair and equitable and are actually promoting health outcomes. With that, I'd like to conclude this edition of the Healthcare Labyrinth podcast, and we'll see you next time. Take care.